everybody. I'm Amajit Maxwell, Healthcare Home Collaborative, supporting you guys basically who are closer to the front line in everything that you're doing in terms of COVID-19. I have you guys all on mute at the moment, but I think what we will do is via the chat function and via raising of your hand, be able to ask questions. The purpose of the session this morning is to run through training around the financial and business model that we've engaged Sapere to support on, and I'll hand over to Chris Peck, who a number of you will know in a moment, and he can introduce himself. So yeah, I mean, ultimately what we're trying to do is create a tool that is relevant to all of general practice and allow the scenario planning to take place. So, but Chris will be, in terms of being the expert, will explain all of that. So yes, welcome everybody. That's all I really need to say, and I'll hand over to Chris to do some more introductions. So you need to unmute. Are you good to go, Chris? No. Is it me? Do you want to raise your hand on the thing, and then you'll come to the, oh yeah, okay.
Thank you.
There we go. Bit of a technical issue there.
You had control over my mute. I was trying to unmute myself, but anyway, so this is the joys of Zoom, actually. It's has a few technical difficulties, but look, thank you everyone for coming along. What we're doing today is going through the financial model, as Amajit said, so I'll try to take you through that as quickly as I can, but we'll also have time for questions along the way in case anything's not clear. I just want to make sure we can cover it off. So look, I really appreciate you joining. I know it's not easy with everything that's going on with this disruption, and I know some of you have kids or the likes running in the background, so look, really appreciate it. So I'll try and make the session as useful and valuable as possible. As questions come, I think there's a function to raise your hand through Zoom, so Amajit will see that and she'll be able to unmute your mic to ask questions. The other way to do it is by typing a chat, and so we've got someone monitoring the chat, so we'll be able to address questions either during the session or at the end, follow up with email if need be. Regarding Zoom as well, it's not foolproof, so what we're doing is we're recording this session, so if you drop off or if anything happens, don't worry, you can come back in and get on and see what you've missed. The other thing is we've got Emily from Sapere helping me as well. She's waving now. So she'll send you all her phone number, and basically if anything happens, give her a call or text her and she'll do what she can to get you back on. Okay, so Emma just talked about the etiquette. So basically, thanks Emily, I see your numbers just popped up there. So before we jump into the model, it's really important, the first thing I say when I'm presenting this model to practices is a bit of a disclaimer. So basically just cover yourself and just say that them using the model at their own risk, and that this does not constitute financial advice, and you recommend them doing their own due diligence around any changes. That's just really important because it is essentially just a tool. It doesn't reflect reality perfectly, but it gives a sense of direction. So just important to say that. And finally, my background before we start, some will know me, but if you don't, so my name is Chris Peck. I've come from Northland DHB and Northland PHOs, where I was involved in the development of this model initially, and then worked with practices in Northland to roll out the healthcare home model. So sadly, I had to leave that role and come back to Wellington, but currently I'm working at Sapere and still involved in healthcare homes as needed. So let's get started. What I'm going to do is share my screen. So hopefully you can all see that screen. So just give me a thumbs up if you can see it. Yep, all good? Great. Okay. So what we've got here is a spreadsheet, and what I'm going to do is take you through how to fill it out and ask questions along the way. So this is essentially the summary of what the spreadsheet produces. And so at the end of all of this, you can work through this summary with your practices. So what we have here is a summary of the revenue, the expenditure, your net profit, and then a couple of charts to put some visuals to what the numbers show. Now you'll notice as well that we have a base year and then 4 years out. So this model is creates a projection by month 4 years out into the future. So it's based around whatever date you specify as the start date. So in this example, I've started year 1 to be the last financial year, the 2019 financial year. Then further to the right, we have the changes in revenue. So within the model, there are a number of components. So what this is a bit of a breakdown by those components. So again, years 1 through 4. And you can see, if we look down there, for example, we've got GP Triage. You can see that in terms of revenue, when you implement GP Triage, you have a reduction in revenue. Clinical Triage. Going further down, Patient Portal, for example, again, a reduction in revenue from implementing it. One thing you'll notice here is that the increase of the reduction in revenue increases as you go out in years. And that's because in the spreadsheet, there's the functionality to ramp up changes. So things don't just happen from day one, the moment you start. It often takes time. So things like the patient portal, it takes time for patients to get on board and start to use it. So that's what we do here. You can see that ramping up effect there. Change in expenditure, so same breakdown, we have change in expenditure. Now this is the non-staff costs. So staff costs are separated out at the bottom. This is everything else. So for example, the huddles has a small cost because you might want to invest in a whiteboard or some space to allow huddles. We have the change in FTE. So as you work through the model, we know that things like phone triage reduce the load on GPs. So that's overall, we can see that the model reduces FTE here. It increased it for nurses, healthcare assistants and admin, but that changes as we look out. And then we've put a cost to those FTE estimates, so you can see the overall impact on staffing. And then a net change in profit at the bottom. The other thing on the summary tab is if you want to drill down into the change in the time component of staff, we can actually do that quite easily here. So this is a lot more detail, but it allows you to see, well, for each of the components, who is the most affected, or what parts of the staffing are most affected. So again, we'll look at triage, and this is showing that GPs have a significant time saving, and that's in minutes. Nurses have a cost because they might see more phone calls coming through to them, and so on. And so you can look at any component like that. And then just below this one is, instead of being in minutes, this is now in dollar value. So all of these time changes on staff put into a monetary value. So that's the end goal, is a summary sheet with all that information. Just before I move on, are there any questions before we get into the actual spreadsheet itself? I'm not seeing anything come up, so. Well, let's move on. So the way this spreadsheet works is we have the summary tab. There is a projections tab. Now this is really messy. This is basically the engine room. So all the information that we enter into the spreadsheet ends up in this, this big calculated engine room. So it's a bit like, you know, a car. You can pop the lid and have a look, but actually you might not have any idea what's going on. And that's okay. And in fact, I'd suggest not tinkering with it, or this car might not go any further. So, so what I'll do when I send this model out is I'll lock down some parts of it so it can't be altered. And this is one of those parts that I think we'll lock down. Those that are interested, of course, can have a look at the calculations if they want. The next thing we have here is the master data. So this is where we enter a whole lot of things around the core model assumptions. So around revenue, FTE, population size, and we spend some time filling that out. And all the assumptions and things we enter here then filter out throughout the rest of the spreadsheet. From here we have 12 tabs down the bottom, and each of those tabs represents an aspect of the model. We've put in a tab for COVID-19, so that's to model the financial impact, but also the impact on volumes that's caused. We also have a tab for virtual, clinical triage, all the way through to other. So other might be anything that we haven't defined yet that you can think of that you might want to cost out, and there's a way that you can do that. So what we'll do is I'll work through an example with you, and it's a fictitious example, but it's based on a little bit of knowledge that I've gleaned through the number of times I've done this with practices. So it gives you a sense of a good default set of things to put into this model. So if we start with the master data sheet, the first thing we need to do, and this is really important, is make sure you only enter things that are in the blue cells. So everything that's white or grey doesn't need you to enter anything. Anything that's white has a calculation in it. So let's start with the date of the analysis. So this entire spreadsheet flows from this date. So year one will start from the 1st of April 2019. So that will continue through to the 31st of March 2020. So I'll leave that there. And I enter the enrolled patients. So I'm working with this practice of 10,000 patients. And then we work in the standard consult length, which is typically 15 minutes. Standard nurse consult length, 15 minutes. And then we enter in some FTE for the GPs and nurses. Admin. Now we assume an FTE is a 40-hour week, 52 weeks of the year. So that works out as 2,080 hours in a year. And then, of course, we know that people take leave. So in reality, the amount of time that people work within an FTE is reduced by the amount of leave that they take. So then the next step, which is a little bit tricky to get from practices because sometimes they haven't looked at their data this way, but we have to split out the revenue that they generate by from where it comes. So GPs, how much revenue do they generate? And this is around standard consultation revenue. And then, of course, nurses, how much revenue do they generate? And then we put in the number of consultations a year. And this gives us a really important figure. So for GPs in this fictitious practice, on average, they generate $12 per consult. Now, that's bearing in mind that maybe their standard consultation rate's $35 or $40, but they might have a lot of kids, which drag that down when the kids are free. So it's really getting that average consultation rate's really important. And again, for nurses, so they do a lot of work, a lot of consultations, but what they actually bill might be quite low. So the average consultation for a nurse is $1 here. I'll just double check to see if there's any questions coming up at this stage. Any questions? No? All good? Okay.
No questions so far.
Okay, just actually, if there are any hands raised, I'll just keep going and you just speak up when someone's got a question. Okay, so this, moving along to the right here, this is a part of the spreadsheet that is the bit that I hate the most. It's quite hard work, but so it's entering in the P&L information that you might be able to get from a practice. If you want, you can enter the P&L information in line by line into this blue box here. And what you have to do, yeah.
Sorry, Chris. One question is, why is the GP FTE not blue?
Oh, yes, good question. So this comes in from the bottom here. So right here, there's two options for how you enter GP FTE, but I wouldn't really bother with this one. I'll just look at this one, and it says based on 10 sessions. So based on them working full time. So if you have 7.1 FTE here, that comes up to here. So just think of FTE in terms of 2,080 hours worked in a year. So coming back to the P&L, so yeah, you can enter in the P&L line by line, and what you would do is you'd enter in, say, the copay amount that they generate in revenue, and you get the option to select what type of thing it is. So we're calling this operating revenue, but there are a bunch of other categories you can assign to it. And then there's activity as well. So is this copay a variable thing based on the activity that happens in a practice, or is it fixed? So copay is obviously variable. So as people come in, you see them, you get that revenue. Capitation funding, on the other hand, is operating revenue, but it's fixed. So you have a fixed population, we're assuming, and that money's fixed through the year. It doesn't change if you see one person or 100 people. And then we look into other things like salaries. So again, this is a little tricky to get from a P&L, so you might have to get the practice to split this out for you. So looking at the GPs, what's the cost for GPs? So that includes the owners as well. So try estimate in that the share that the owner might get in terms of the profits and things. So we're trying to look at the total cost of GPs within the model.
Sorry, Chris, is the GP revenue figure only copay?
This one here. So this copay amount includes GP. So if you look over to here, it includes the 360 copay generated from GPs and 20,000 from nurses. So it's the total. So yeah, as we go down, we then can categorize these different salary costs. I won't go through all of this in too much detail, but if you want to, don't worry about filling out all of this information in the P&L. I would even just take what I've put in here as by default. and just tweak these values that are in here, because it's all set up. It's got the type of activity and the type of revenue or expense that it is. So you can always just run off this and just enter your own values in here. And that's it in terms of this master data sheet. Is there any questions about anything within the master data sheet before we move on to the rest of the spreadsheet? Okay. So each of the sheets, now we'll start with the COVID impact. Each of these extra sheets have a range of assumptions that are relevant for this particular component in the model. So for example, and it's the same rule as before, so only enter things into the blue cells. So let's work through the COVID one very quickly. So what we've done here is we have trying to put a cost to the disruption that's caused by COVID. So the things are, this resulted in a drop of consults, typically, and it's also resulted in a move away from face-to-face consultations to a more virtual approach. So we've tried to model that. We've also built in things around the additional revenue that comes in from the ministry. There might be a wage subsidy that practices can apply for. And within these things, we've also built in the ability to turn on or turn off these impacts. So supposing you want to look at the impact of COVID, you can use this flag here and say, yes, we want to include that in the model. And it's just a little drop down. But if you don't want to see the impact of COVID in the model, we can turn this off. So then it becomes more like just a normal primary care financial model. But let's turn it on for now because we want to see the impacts. So now as changes happen, so consultations will drop. That will obviously impact on the availability of the utilisation of GPs and nurses within the workplace. So if consultations have dropped by 30%, there'll be a lot of people underutilised. They may even be sent home. So this is an option here to go, do we want to recognise those savings? So if you're employing contractors, you may have been able to let them off for a period of time. But if you had salaried staff, then clearly you have to support them through this period. So you don't actually realise those time savings. So this is really just a flag to turn that on and off. Next, we look at the start date for this disruption. So we have two periods. The first is period one, where we're in level 3 and 4 lockdown. So in that lockdown period, there's a real movement away from face-to-face consultations to virtual. And in fact, it's on the government's website around COVID advice. So we've assumed that period will last for 3 months. So we know it definitely lasts for 4 weeks and probably another period of time after that. Within that, what is the percentage reduction in consultations that a practice has seen? I'm assuming 40% in this case. Then we have the start of the second period. So that starts straight after the first period. And the second period is when we enter levels 1 and 2. So there might still be quite a bit of social distancing that's going on. So that may have an impact on the way you have your seating arrangements in practice. So all of these things can affect the volume slightly. People might also feel like they don't want to come into a practice if they don't need to. So there's an opportunity here to both model the length of that period and also the disruption that's causing in terms of consultation volumes. So I've assumed here a 5% drop over that next 6 months. So then we have some funding. So this is taken from what the ministry will be sending out to practices. I think they may have already been paid this, and it was a lump sum as far as I'm aware. So we've modelled this, and all you need to do is enter the patient numbers in here to get the calculation. I've entered in a calculation for the wage subsidy. So again, this can be turned on and off. Now, the note for here is if you're claiming the wage subsidy, then clearly you're retaining staff to be able to do that, to support them. So if that is turned on, if you decide that you are claiming the wage subsidy, then you definitely have to have this here turned to no. So the business won't be realising those savings from the reduced time. But I'm guessing there'll be a lot of practices that don't qualify for the wage subsidy. So I've got the ability here to turn that on and off. So you simply enter the number of staff you've got working 20 hours or more, and then the number of staff working less than 20 hours. And it will calculate a wage subsidy. The other thing that we've had feedback is that you will see a greater shift to virtual consultations. So basically what we've got here is the ability to add the shift. So I'm saying even if consultations have dropped 30%, within that reduced volume, we're actually seeing only 70% now face-to-face and 30% done virtually. And you can tweak that for the second period as well, if things move back to more of a face-to-face arrangement. And then there's additional funding for COVID-19 assessments. So this is, I'm not sure of these parameters in here, but the funding amounts are right. So you enter how many assessments you think you will have done through the COVID period, both periods here. So 10 simple and 5 full ones, perhaps. It may be quite a lot more than that. And then you enter the amount of time that GPs and nurses are spending to do that. And that's it. So that's all that you really need to do in this tab. It's incredibly flexible, so it can be turned on, turned off, and adapt the parameters as needed. So we'll move on to the virtual consultations. So this is where we're getting into the actual components of the model. So this is probably the first key one right now. So what we need to enter here is for GPs and nurses, and by virtual consultation, we are meaning phone calls and video conference. So different from phone triage, but these are actual consultations done over the phone or via virtual. So we enter the percentages that are currently done virtually in terms of the consultations, and I'm assuming in my practice, fictitious practice, it's really low right now, and even 1% might be a stretch for many. But then we might want to target. So sorry, I'll just step back. Everything from here on, let's assume this is the model under normal circumstances. So ignore that COVID's happening right now, and ignore that virtual consultations have gone up quite a lot. But when we get back to a normal state, what do we want the business to look like going forward? So what I've said here is, under a normal scenario, we would hope to have 10% of our consultations going through for GPs and nurses as virtual. I want to start this change immediately once COVID lockdown ends. So what we're doing here is putting in a start date for when this change kicks in. And it doesn't happen overnight. So we know it takes a while for patient behaviours to change. We've had a really great kickstart with COVID, so there's a real opportunity to leverage off that now. But under normal circumstances, it takes a while for the patients to understand this change, to get used to ringing in or having a virtual consultation. So we've got the ability to ramp that change up over 36 months. So all it is a straight line extrapolation of that expense over 36 months until you get to full maturity. So I'll leave it there. I could actually drop it to 24 months because I don't think it'll take that long. Then you get to set how long you think the virtual consult will take. So we've heard that GPs are knocking them out in 10 minutes through this period because there's less of a need to chat about things. So look, 12 minutes might be a amount you might put in there. And then you want to put in the fee that you'd charge for a virtual consultation. Some practices choose to charge the full fee as a standard consultation. Others might want to reduce it to incentivize people to use that mechanism, particularly if it saves a little bit of time. Remember, important thing to remember here is when you're looking at the fee, it's not the standard fee for this, it's the average fee. So there will be some kids that might get a virtual consultation, you know, sitting with their parents or the like. So you may want to just make sure that, just factor that in as you put in the average. So these are two boxes now, one looking at any first year one-off costs and the other looking at ongoing costs. Now these are fairly standard throughout the spreadsheet, so I'll just talk about it here, but we'll skip over the other tabs when we get to this bit. You can enter anything in here that you think might be a one-off cost. So maybe you need to invest in fibre. Maybe you need to invest in something to make this happen better. So you might want to put in a cost here. And that might have an impact in the first year. I don't know what that impact will be, but let's just say there's a $200 establishment cost or more. And that will then come through. Again, there might be some ongoing licenses for the software to do virtual consultations. You get to enter that in here as an ongoing cost. And that's essentially all there is to the virtual consultation sheet. Again, any questions, just raise your hand and Armajit will bring you through. We'll move into clinical triage. So with clinical triage, we, again, same sort of thing. We pick a date when we want to implement triage. I've assumed this starts on the 1st of the 4th, 2020. Ramp it up. So sometimes, I think this one, it doesn't take too long to establish. So once you set a schedule and you get your practices ready to start, you might have all the GPs starting at the same time. So it might just take, the reason why there's an option here to ramp this up is it might just take 3 or 4 months just to get used to the process and, you know, get those good gains in terms of the resolution rates. But that's, you can change that. So average call in minutes for a triage call, experience has shown me it's around about 4 minutes or 3 minutes. So you just add that in there. There's an underutilization that happens. So basically, I'm not sure if how much I need to explain this, but basically if you schedule half an hour of time for a GP to take triage calls on any given day, demand fluctuates. So you'll schedule that in, but maybe they only use 20 minutes of that one day, but they use the full half an hour another day. So over time, you get an amount, a percentage that's unutilized from that allocated time. And that extra time can be used for paperwork. So it's not lost time, but it just means that it changes the number of patients you can triage. And then we assume it's offered every week of the year. If there's any additional time that admin need to put into this to support the triage process, then we can enter this here, and that's in the number of seconds. I assume it doesn't increase their time, but you may want to add something in here if it takes longer to explain the triage process to patients as they call in. So we can decide as a result of triage, there are certain outcomes that might occur. So one of them is that you provide advice to the patient, and that's all. And a lot of practices will provide that advice within the 4 minutes, and it actually prevents a person coming in for a face-to-face. So they won't charge for that. Others, the other option is you might write a script on top of that, and it's perfectly okay to be charging for a script fee on top of that, and so we can enter that average script fee here. And some might even extend into a slightly longer conversation, and this is where it might then become defined as a telephone consult. We try not to allow this to happen too much in triage as you're rolling the model out, but it does happen, and so there's a function here to factor in when things do end up as a telephone consult. So all of these are changeable. The next thing we need to do here is work out the demand for patients. So there are a number of ways you can do this with your practices, and I won't go into how you get these numbers, but once you have them, you can then work out the number of patients on any given day of the week that are likely to be phoning in and requiring a callback. So often Monday is higher than the rest of the week. The COVID disruption, we're able to factor in this. I think this is the only sheet where I've factored in any other COVID disruption. So the advice that we've seen from some areas, and this is just, and you can, and I would recommend tweaking this based on what's happening in your local area or what's happening for the practice. But a 250% increase in the volumes going through triage during COVID is not uncommon. So that's what I've done with this fictitious practice, is increased it to 250% more than the baseline. So the next thing we have to do here is we can enter how we think the calls are going to get managed. So if we look here, based on the numbers that we've input so far, 10,920 triage calls will be completed within a year. Of these calls, we're assuming 60% will end up as a GP consult, 5% will end up as a nurse consult, and 35% will get resolved over the phone. You can change these numbers based on your own knowledge of the system, but if you find that you're just not sure, I would go with what's in here by default. It's based on what I've observed to date from a number of practices that I've worked with.
Chris, there's a question from Jeannie. What is the time period used for additional reception time? Is it weekly, monthly, or is it per call?
It's per call. Sorry, good point. So it's likely, that's why it's in seconds. So it's likely to be maybe 10 seconds if need be. So let's just follow this through. So if we've got 10,090 calls that came through in the year, 35% were resolved over the phone. That's 3,822 calls that would otherwise have gone to a face-to-face consult, is the assumption. So within these 3,822, 50% have advice only. 45% will have a bit of advice and have a script as well, and 5% might result in a telephone consult, so that longer conversation. And again, these numbers are based on what was observed in reality. And just this section here is a change to these outcomes based on what's happened currently. So we've seen that the number or the percentage that's coming through triage has increased a lot. So we now have, over this 3-month period, almost 10,000 calls. So that's almost what you've seen in the whole entire year that we're modelling up here within 3 months. And we've changed the percentages here. So now we're saying 60% get resolved over the phone. And that probably reflects, a lot coming through around COVID and just wanting some advice around that. And again, these percentages haven't changed, but you can alter these percentages here just to your circumstances. Further down, you'll recognise this. So again, if there's any setup costs in terms of triage, you might want headsets, or there might be some other, you need a bigger monitor or something. There might be some costs there. So enter those there as a one-off cost. And if there's any ongoing costs, I haven't entered anything here because in my experience there's not been a lot in terms of costs. And that's all. So just as a quick note for anyone, it's a bit like looking under the hood of the car again, but if you are interested, there's some calculations down the bottom on how it turns the numbers up above into the revenue that's foregone, the revenue that's generated through triage, and the time savings as well. So these all then get linked back into the summary, but again, you don't have to look down here. It's not that important. So we'll move on to huddles. And same thing, working through the blue boxes. So there's a start date when you might want to implement huddles. With all of these, just a note, with all of these components of the model, clearly if you're working with a healthcare home, these are all mandatory parts of the model that they need to at least be working towards. But if you're just working with a practice to try and understand how virtual consultations are changing and how that will affect their business going forward, you may or may not choose huddles as a component you want to put in. Personally, I think it would be a fantastic thing to have in because, particularly in times of isolation, a 5-minute huddle or a 15-minute huddle in the morning could be quite valuable. And it's a really important part of the model as well. So we put in a start date. We also estimate, are these daily huddles? If they are, then we'll say there's 5 of them per week. And then the length of time. So usually they take up one consultation slot of 15 minutes. And we do these throughout the year, 52 weeks of the year. The huddle is attended usually by everyone. You need to keep some people on answering the phones. You'll keep those people there, but you want all of your clinical team and healthcare assistants in those huddles so they can work through the daily business. There's an option here to put in a percentage of FTEs that might attend, or if you know the numbers, there's four GPs, then you can put that in instead that might attend. But it's an option to put in either. And then again, any one-off costs, and then any ongoing costs. So then we look at healthcare assistants. So these are actually a really important person within the healthcare home model. And they're quite useful, obviously, for freeing up time. I don't need to go into the reasons for it, actually, as I'm thinking about that, given the audience I've got in front of me. So what we've got, again, is you put in when you might want to implement them. So if you already have a healthcare assistant in your practice, you might just put that in as today. But if you're looking to employ another healthcare assistant, that's where you might put in the start date here. So so this is the start date for when all of these changes will go from. It may take some time to train a healthcare assistant up or to redefine what the existing healthcare assistant is doing. And if that is the case, then you put in a little period of training. So six months might be over-egging it, but let's put that in for now. So in my fictitious practice, I have one healthcare assistant presently, and I want to employ another one. So what that's done is given me an extra 115,000 minutes of the year to utilise for that healthcare assistant. Healthcare assistants get paid lower than a nurse, but more than administrator. So I've put in an hourly figure here that I think reflects that. And again, there's a chance to put in any one-off costs or ongoing costs. So the important part in this tab here is trying to work out, if you're employing a healthcare assistant, what are the things that they're doing that are going to release time from from nurses particularly. So this blue box here is where you can start to enter that information. So for example, if you're moving restocking of consult rooms to the healthcare assistant, that might take a nurse 4 hours a week. So you might put a -4 there, and then it will translate to 4 hours a week for the healthcare assistant. So you can just basically enter in tasks into here. So blood pressure, and that might, whatever it is, -3 hours and 3 hours. So all that's really doing is transferring that time across to the healthcare assistant. And you'll see at the bottom is we can total up the number of hours that we've saved for the nurse, and then total up the number of hours that healthcare assistant's consuming. So I'll take those out. What I've done here, this is quite a process, and you would often work through this with a practice, listing out all the things that nurses are doing and thinking what things could actually be shifted over. And it's also part of a process where you look at what GPs are doing and moving those to nurses as well. So, but what I've done here for expediency is put in a line which basically just says various tasks moved from nurse to healthcare assistant. And that allows you, without having gone through that process, to at least estimate, well, I think having one healthcare assistant will save me 30 hours of nurse time, roughly, a week. And, and you know, I've said that takes a bit more of the healthcare assistant's time because maybe they don't do things quite as quickly as a nurse, or maybe the nurse needs to support the healthcare assistant through training and support from time to time. So it's not a direct match. So what I've done here is just entered in some numbers that worked in my situation.
Chris, Mark made a comment of it's also handy for health coaches too.
Yep, absolutely. So you could also use this, instead of calling it healthcare assistant, think of it as health coach as well. And put in some sort of average hourly rate if you wanted to combine healthcare assistants with a health coach in terms of the FTE that you're looking at. So we'll move on. Then we have the patient portal. So this will be utilised a lot more through the lockdown period, hopefully. But again, looking at the normal situation, we enter in, we've got the enrolled population, which we got from the master sheet. Then we can enter in the eligible population. And we know that the eligible population is 70% of the total. So that actually gives us a maximum level that could be utilised or uptake through the portal. So we put in the current percentage of portal users now. So what we mean by a user is someone who's actually registered, activated, and they actively use that portal service from time to time. And then we want to put in the target percentage. So I'm putting in 40% as my target. We'll start that from April. And all that start date does is it starts incrementing the percentage that we get on the portal up from that date. So if we start at 10%, then on the 1st of April, we'll start to increment towards that 40%. Because we'll be doing a push on that. And it takes a long time. We know from experience, 3 years to get up to 40% might seem reasonable. Even those that do a push, they might get a big jump, but you find you know, the gains in terms of getting patients onto the portal are harder and harder. So it takes time. So we put in 36 months in this case. In terms of the calculations, what we know about the patient portal is that everyone that uses it consumes a bit more GP resource because there's a lot more they're doing in terms of answering messages or writing scripts through the portal. But we see savings in terms of FTE, in terms of the nurse and in admin. So nurses doing less scripts and less following up of messages, and admin as well, booking less things over the phone. So we get those savings. So all this model is doing is really working through those assumptions and multiplying that out by the percentage increase that we hope to see through the portal. Again, if there's any initial costs or ongoing costs, there's the ability to enter these into the blue boxes here. I'll just give you an opportunity. If there are any questions at this point, just let me know, because we're getting into MDTs and year of care, which are a bit more intense. So anything up until now, just ask away. Okay, no, that's good. And any questions after this session as well, feel free to fire any questions my way. So now moving into multidisciplinary team meetings. So this is part of the model that deals with proactive care for patients. I won't go into that because, you know, you guys know about what this means. But what I want to show you is how we might cost some of the stuff out. So if we again look at the start date, when might we want to implement triage? And I've actually put that in as April, but it's the sort of thing that might come further down the line as a practice is becoming more mature. So I might bump it out a year or so. And it might take some time to get used to the process. And so you might start with a few people at first, but then broaden it to more people as you get used to it. So what we're assuming here is you might hold one multidisciplinary team meeting a month. So that might be where all your clinical staff come together and have a discussion around particular cases that they want to present and get that feedback from other experienced clinicians in the room. I'm assuming each meeting takes 60 minutes and you'd get through 10 patients in that time. If you have a structured process, agenda to work through, you get through 10 patients. So some people might like to run these as one GP and one nurse attending per patient, but I'm suggesting in this example, I would have my core clinical team together to discuss all the patient cases as both a learning exercise and useful for patient care. There's the option here to add additional resource required. So if you need someone from admin to take meeting notes or a healthcare assistant to take some meeting notes, then they can be present and you might allocate that here. Some other costs here, so any one-off costs and then any ongoing costs. So one of the things I've entered in here is I think you might, when you get a mature model, you might have external providers joining your MDT. They might do that for free because they may see benefit, but I've just costed in here $100 per meeting for an external provider. One of the things when I'm working through this model is I always try to be a bit more on the conservative side. So I don't really want to present a picture that practices are going to make a huge amount of money from this model or from these changes. I prefer to be a bit conservative on the costings, and then if need to tweak and do some sensitivity analysis on that down the line. So this is my example here where I'm being a bit conservative, and I just assume that there might be an expense here. And that's all for the multidisciplinary team meetings.
Got a question from Jessica. Chris, will the COVID-19 section be updated to include the new funding coming through? Might have to be flexible in case they change again.
Yeah. It has a section here on the new funding, on this funding, but if there is a different formula that comes through or a different mechanism of delivering funding, then we'll just need to tweak the spreadsheet, but it wouldn't be hard to tweak. If these rates, if it follows the same mechanism and these rates change, then we can just open these up to be blue fields that those funding rates can be changed. So it's flexible, but can be easily tweaked if the model changes. So multidisciplinary. Now the next thing we'll look at is year of care. Now this is, you can look at this as year of care or care planning. So that process of developing a structured plan around an individual patient based on what their needs are and what their wishes are for their care. So this is one where, and it kind of is a little bit like the Care Plus funding that comes through general practice as well. So what I've done with this sheet is added the ability here to turn this on and off. So the reason why, if there's the revenue that comes in for Care Plus. Now, if you design your activities around year of care or around care planning to meet that revenue that comes in, so your expense equals your revenue, then it has no net effect on the bottom line. So if you don't want to go through and run through these calculations, you can just turn this off. And then anything that's calculated in here gets turned off and we don't see it in the final summary. But I will take you through this because it's useful to see how this might be costed out in practice. So we have an enrolled population of 10,000, and I'm assuming that 5% of my patients will have a care plan, which gives me 500 patients. I'm starting from a zero base, so let's say I've developed no care plans whatsoever. So that's what I enter here. So I know I've got 500 to complete. I might already be offering Care Plus services to these 500 patients, so or similar sort of services. So I'll say we're already receiving that care. And the start date, when do I want to start developing these care plans and changing the way we work with patients? And this months from start to achievement of target. So that's achievement of all of those 500 care plans. So we'll build up all 500, and if we can do that over a 12-month period, that's what I've put in here. So the first thing we need to do here is think about, and it can be tricky to think this one through, but it's useful for the model. So what does an average, the average activity look like for someone who's had a care plan developed? So thinking it through, the development of the care plan with a patient, plus 15 minutes paperwork, I'm saying takes an hour of time for the nurse in terms of consultation, plus 15 minutes for paperwork. And there'll be no charge for that for the patient, because you want to be bringing those patients in to do that. Then I'm assuming there might be one GP consult throughout the year, and they might charge a copay of $12 for that. And there's this occurrences column is how many times this occurs in a year. We might have a nurse consult of 30 minutes, and you might do 2 of those face-to-face nurse consults through the year, and you might charge a couple of dollars copay for that. Then there might be a series of brief interactions with the patient, phone calls, catch-ups. And so I've just costed those out as a quick 10-minute phone call with a nurse, and we might do 8 of those through a year. So this is just an example, and there's many, many ways that this could look, but this is my attempt at trying to put in an average of what it might look like for a patient. And then there might be some funding that's provided per patient. So if you get Care Plus funding, then you might work out that the average that we get for a patient is about this much. Then we want to compare that to what existing activity happens for these patients. So this is a really basic scenario where they simply come in 4 times a year to see a GP, and that we don't charge a copay for that. And we get some funding to offset that copay. And that's all. So that's that sheet. Again, there's some options to build in first year costs and ongoing costs. Then we move on. There's only a few left, guys, so we're doing well. Then we move on to call management. So this is taking phones away from the front desk, putting them in the background, and making sure that phones are answered in a timely manner. So a really important part of the model, particularly if you're implementing phone triage as well. So again, you guys will know a little bit about how to estimate how much additional FTE admin will need to do this, but what I've used in the past is a couple of useful tools online that you can use. So there's some links here to some calculators, and what you do is you enter the call demand throughout various hours of the day, and you put in your service parameters. So if you want 85% of calls answered within 30 seconds, you can enter those parameters. And you might want, I think, 5% dropped call rate, less than 5%. So you can enter that stuff into these calculators, and it gives you an idea of how many people you need on to answer the phones to make sure you meet those service levels that you want. So that's what I've done for my example. I've done that, and I found out that I need 1 more FTE. So that gives me some time to play with. And we're going to start this straight away from the 1st of April, and it's going to kick in straight away because we're going to employ that staff member, and from day 1 they'll be answering those phones, and we'll be getting the benefit from that, and we'll be seeing the expense of that as well. There might be some first year costs, so call reporting is an obvious one. A lot of practices don't have very good reporting on calls, so they don't really know how they're tracking. So often there's a cost involved in setting that up, and it can be quite a lot, $1,000 or $2,000. So I'll put in that cost there. There may also be some changes to change their phone setups. And there might be some ongoing additional costs in terms of fibre costs or the likes. So we'll move on to extended hours. The key assumption with extended hours is that we assume that staff don't work more hours during the week, but maybe you realign the shifts to match with the demand that's outside of hours as well as in hours. So yeah, staff hours don't change, but when they work changes. So the way we've modelled this is when staff are working outside of hours, in a lot of cases they'll be paid time and a half for working outside normal hours. So we work out how many people, how many extra hours will be worked per week. So if, for example, we extend our hours out to 6 o'clock, 5 days of the week, that's 5 extra hours a week that you'll need a nurse, a GP, a nurse, maybe a healthcare assistant, and your admin. And if they're working outside of those hours, then we bump up their pay rate by 50%. Then again, any first year costs you can add in here, and then any ongoing costs. So the ongoing cost that's relevant here, which I've put in as a standard, is the variable cost. So this comes all the way back to the master data when we filled in the P&L and we put in variable expenses. So all of those things that are variable overheads, we've got these in here. So as we extend our hours, those variable costs extend out as well. So if I go back to extended hours, that's all that is doing, is it's extending out that variable cost for the number of hours that you're extending your business.
Chris,
yeah.
There was another question from Michael Chen. Maybe some fields are obvious, but would be great to have the cost or revenue items formatted to dollar currency or accounting to separate the format from FTE or units such as minutes, etc. Thanks.
Yeah, good point. We'll definitely do that. Cool. And finally, this is really a catch-all sheet. So anything that hasn't been costed out so far, we've got the bulk of the model in here, but there might be some other things that you can think of where during the implementation of the model, there's a bit of release time that you want to factor in of staff to learn about the model or about the changes or to embed things, because it takes time. So there's two parts to this. There's staff release time, and then there's some other expenses that you can put in here. So in terms of staff release time, if there's, let's say, training, I'll put that in, and it's really just relating to GPs and nurses here. But let's say in the first year, there's 20 hours of training. But basically what it's doing is it's working through the hours that they're spending, and also as they're doing that, there's a bit of revenue that's foregone for them being taken off consultations. There might be some ongoing staff release, so I'm thinking of things like continual improvement of processes, so you might want to factor in some release time around that. Then we look at expenses. So if there's anything that we haven't captured elsewhere, there's a chance really to think about these here. So one of the things that I've thought about is around stock management. So one of the things we'll do is go into a practice and make sure that there's efficiencies through the way that they stock rooms. So roughly what I'm costing out here is if you implement a really great system, then you might save on your stock costs. So I'll put in about 10% of the stock costs, which again come from the master data. So if we go back to the master data, we can see clinical supplies might be a line that you want to enter into your P&L here. So we can use that. So if 10% of 100,000 is 10,000 saving. One other potential saving that I heard of recently was the paperless prescription. So there's e-prescription, e-prescribing, but paperless prescription is something that is in addition to this, and the person I spoke to said it's a significant saving to their business. So I've put that in as a thing that you might want to put in there as a saving that's ongoing. But this is entirely flexible for any other things that you might think of that haven't been captured through the model. So if we're to go back to here, back to the summary, that's everything in terms of the model costed out. If we go back to the summary, we can see that, and we'll go through this a bit more carefully. So the base here was that we had a $2 million for this practice coming through from capitation, so that's our population revenue. Activity revenue, copay and the like we saw 380,000 coming through. And then we have COVID subsidies split out as well. So what changes? So from year one, we're assuming, so to avoid having too many moving parts in this model, we've assumed the same population going through and the same activity in terms of total volumes going through. So everything that you're costing out is based on this base level. It just avoids any confusion around, oh, my volumes have increased, how much of this change is due to volume increase and how much is due to the actual component. So it just gives you a good baseline. So in this case, in year one, we're seeing a reduction in activity revenue, and we're also seeing a bit of an increase in COVID subsidies. In year two, we see a further reduction in revenue, and so on. If we were to go over to the right here, we can see what's driving that change. So these are the changes in revenue based on the different components. So we're seeing that the COVID disruption is causing a reasonable amount of disruption in terms of the revenue. So that first period of disruption started, I think I've started it on the 1st of March. So it spans those 2 financial years, but that's the reduction in revenue from that first period. And then the second period has some further reduction. There's the additional COVID funding from the ministry. Clinical triage is reducing revenue because we're taking people off consultations and diverting them to answer phones. Now, what we've done is for virtual consults and clinical triage, we've split those out as COVID impacts versus non-COVID impacts. So that's your normal clinical triage costing under normal circumstances. But with COVID, this is the impact that's happened here as a result. So that's the additional reduction in revenue as a result of the COVID. Then we have virtual consults, and again, we're generating a little bit more revenue through COVID as a result of doing more virtual consults than previously, so that's an increase in revenue there. So basically you're able to then work through all of these to see where that change in revenue has occurred. So if we go back to the left here and we look down the expenditure, we can see that we're currently, in the base year, we spent 1.278 million on GPs, and that drops a little bit as we move out. And similarly for nurses, that increases. So we can just see that, and then all other expenses. So in this model, what we can see is that if our base net profit was $80,000 in year one, result of the additional subsidies that are coming through from the ministry and also every other change, we've actually got a bit more net profit that's increased a little bit. In year two, that drops, and that's probably just due to when the timing of that ministry subsidy kicked in here. But then ongoing, year three and year four, we're sitting there around about 36,000 in terms of a net profit. So it has dropped from the base, but it's coming through as still a positive. The line below is just showing you how things have changed from the base. So this is a 20,000 increase. This is a drop of 91,000 from 80,000 base, and so on. And just a couple of very simple charts. They're not particularly pretty, but they give you a sense of the numbers in a picture. So if we wanted to look into the expenditure and where the changes have occurred, so these are the expenses that were added in, such as things like the whiteboard for the huddle, the variable costs from extended hours, those variable operating costs, overheads, perhaps the ongoing fees from your virtual consults, such as your subscription fees, and maybe setting up call reporting. So then we can look at the staff expenses and see what's changed there. This box is showing you the change in FTE, and this box is showing you the change in dollar amounts. And I'll take the point before about maybe put some dollar signs in front of these to make it a bit more explicit when we're moving from FTE to dollars. And then if you really want to drill down further, you can go into the different components by staff time as well. So the good news, everyone, that is the model in a nutshell. I'll basically open up for any questions that you have about this. So Armajit, is there anything coming through?
Yes, we have a question from Jeannie. What I'll do is, if you guys raise your hand and I can take you off mute. So do you want to stop sharing your screen? Is that easier, Chris? I'm going to stay in the model actually, and then you can point to it, I guess. But I'll take Jeannie off mute, and then she can answer her question direct, and I can do the same for others.
First of all, thanks. That's been amazing and a really awesome explanation, and a lot of learning there from me. So I've actually got two questions. My first is, in the other tab, would it be possible to include admin practice managers as a separate column? We have monthly forums, they do some reporting, they work on issues around setup and reporting and things. So I think that their contribution is actually definitely valuable in terms of their time and the cost to the practice.
Yeah.
So that would be my first sort of question / suggestion. And then secondly, I'm a little bit, I've found there's been some confusion in terms of the GP triage form and how we've morphed from using that to manage acute same-day care demand in BAU to it being used as a tool for telephone consultations. So effectively skewing the data quite a lot, where I've got one practice who was doing high volumes of GP triage who are now doing telephone consultations and appearing to have no GP triage over this time, to others that are using it all the time for telephone consultations as a tool for managing that process internally. And I don't know how others are finding that, but for me that's creating a lot of variation in data. And actually I have one third question. The hourly rates for staff, when you're looking at the calculations, where do you enter that in terms of what the real cost is for each practice?
Yeah. Okay. So I'll just run down your list of questions. So firstly, yes, we can adapt that to factor in those other roles. So happy to do that. It's not a big change. Secondly, around triage, so I can speak for one of the systems that I'm aware of, but you're right. So if the data's getting skewed, then what you may end up entering into here around that COVID disruption and what you might assume the resolution rates are, etc., might be out. So it's trying to understand what's really happening. So one of the suggestions you could put into place is perhaps asking practices to code those in a different way. So often there'll be a way to code the outcome within the form, or whatever type of form you're using. So if there's a separate code that could be developed for those, the way that they're using it, which is really outside of the scope of what the tool was designed for, then maybe that's a way to get down to the guts of what's actually happening. But if you don't have good numbers, maybe just use what's in here, or ask a few of your colleagues about what they think the right percentages should be in here for that COVID disruption.
Okay.
In terms of the hourly rates, it's a little bit hidden actually. So I'll just explain. It comes from here. So when we enter in the GP salaries, we know that we have 1.278 million spent on GPs. We also know we have 7.1 FTE. So all we're doing is taking that number divided by 7.1, and it gives us the annual rate. So what I can do is perhaps make that more explicit and put a little box down here or something that shows the rate that is being used in the model.
I guess in terms of that, whether others would find value, and or whether just in terms of using one figure that then is ratioed against the FTE. I mean, swings and roundabouts, I guess. What do others in this chat think?
They're all muted, Jeannie. They might do it through chat, but it's tricky. We do have a comment from Mark Bella. Are you covered off, Jeannie, in terms of?
Thank you.
That's good. Thank you. I'll unmute you, Mark, and then you can ask your, I think more was a statement, but over to you. Mark Vella, did you want to make a comment? In the chat, you asked the extended hours tab is interesting as it's often tricky as to whether any increase in revenue matches additional capacity costs. Did you want to make any comment, Chris? Because maybe Mark may have.
So extended hours. So I haven't put any increase in revenue in this tab. The reason being, I'm assuming that if you're just shifting when staff members start and stop, you're not actually increasing the capacity for consultations. You're just moving the time of the day that they occur. So I'm not. Oh, do we have Mark on now?
Yeah, sorry.
Yes, I think so. Sorry, I was just.
That's all right.
I couldn't unmute.
Sorry.
Yeah, no, that's good. And I suppose too, there's the possibility of enrolment in the extended hours as well, which would add to your capitation base longer term.
Yeah.
But it's always a tricky equation as to you're thinking that you're actually getting more co-pays potentially, but actually your staffing costs are actually well and truly potentially outweighing them.
Yeah. Yeah.
So this was very helpful.
Yeah. Yeah, it almost always comes through as a cost. I don't see how it would be a saving for a practice.
Nothing else coming through at the moment. Were there any other further questions? Oh, one's coming.
There's one from Bevan.
Yeah, from Bevan. I'll just unmute. What I might do is I might just go into unmute everybody now, but we'll raise your hand in terms of we'll pass the baton over, and then that'll just be easier. So if you're not speaking, if you can maybe mute yourself. So Bevan, over to you.
Hey guys, hey Chris, thanks for today. Can you hear me?
Yeah, absolutely.
Cool, mate. Two questions. I missed the start. I was on another call. In the activity revenue or somewhere there, is there an assumption for healthcare home funding?
So it's a really good point. In this model, there normally is, but we've adapted it to take that out.
Okay.
We could add it back in, but we've taken it out because this is going to be used for any practice, regardless of
across the board.
Yeah, that's right. So we don't really want to put that in. But look, to be honest, it could be added back in if it would be a preference. It's tricky because every area has different ways of doing it.
Yes.
So you have to kind of think of all the potential possibilities that it could be funded. So I think almost my preference is to take it out, and then you can think about what the funding might be on top
whatever
of
it may be. Cool.
Yeah.
And the second one, I just missed some of your assumptions in the call management. Could we revisit that?
Yeah.
In the call management
Oh,
one?
sorry, call management, absolutely.
So I missed what you said about how you made the assumption that it was an extra FTE.
Ah, okay. I'll see if this works. So there's a couple of resources that I've leaned on in the past. Here we go. And what these do is they help you to, if I go advanced, they help you to understand the number of staff that you'll need on to answer calls. So I would work through this, and if I knew my practice had 100 calls coming in the first hour of the day,
What's it?
Then in the average handling time, I might say 60 seconds.
Yeah.
Yep. And in the service, I want 85% of calls answered within 30 seconds. I'll just go calculate. So that tells me to get that, I would need 5.5 agents, basically.
Got it. Yep.
So you can so what you can do, and then I'll compare that to what I had in my practice. I might have had 4 people answering the phones. It's a big practice, so 10,000 practice. So 4 people seems reasonable to have supporting front desk or answering phones possibly for an hour in the morning.
Yep.
So yeah, so that's all that's doing. And then I'll come back to the spreadsheet and I just add in whatever the difference is. So it's a little bit of an art, but these tools help. They give you a bit of an insight into what you might want to do. And
Right.
there's good descriptions within those tools of how to use them as well.
Cool. And so thank you. So did you kind of reverse engineer any change in administration or reception based on those calls being managed in a different way?
In terms of
Savings?
yeah. So
If I'm here, I've disappeared.
there's nothing explicit in here. So all this is really doing is costing out the additional FTE.
Okay.
But you're quite right. There might be some things around, look, if you've got a bit of downtime, then admin could be taking some work off other clinical staff perhaps, which if there were a situation like that, you could actually start to put it in this type of thing here. Maybe you could say here, so nurse or HCA time saved from admin or something. And you might say how many hours in a year are saved. So, maybe 20 hours in a year or something. Oh, and actually that's where I'll put in maybe the admin roles and stuff.
Yeah,
in there as well.
you're spot on. You know where I was going. Or you could easily use this if you had some sort of off-site call answering or support. You're back and you're saving to HCA or whatever.
Yeah,
Cool.
exactly. And
Thank
so
you.
you can add those in here in terms of other expenses. Or,
Yeah.
So, yep,
Thanks, Chris. Nice one.
that's okay.
Thank you. We have a question, Helen, over to you. But everyone else who isn't asking a question, could I ask you to, because you've got control of your mute now, there was just a little bit of background noise, but over to Helen to ask the question.
Hi Chris, it's been a really informative session, thank you. Just one question, the tool is based on set ESUs and set co-payments. Is there any way that it can be used if you've got a practice and set price?
Sorry, you just cut out a little bit there. What was the last part of it?
It's all the tool's based on set ESUs, but you might have a practice wanting to grow. Is there any way that you can do the projections based on growing ESUs?
Look, I haven't built that into this model deliberately because I was trying to keep things a bit static to assess the impact of the changes. What you could potentially do, if you wanted to go down that path, just trying to think how you might do that. In the master data, that's where you add the number of consultations. So you could potentially just do a scenario, look at your summary, save that information, go back into the master data and perhaps tweak enrolments, tweak consultations up a little bit, look at the scenario again. It's not seamless, but you could then do it, because then you'd be modelling, for example, if I tweak this up to 35,000, then the numbers here will change a bit based on those new volumes. So it's not perfect, but it might give you some ability to do that. It may be a little bit of work. It would be a bit of work to change, put in a growth factor, but it could be done if it was required. But my preference would be to leave it as is for now anyway, but it could be done down the line if that would be a preference of the group.
Awesome, great, love it anyway, Chris. It's really, really great session. Yeah.
That looks like yeah, that looks like all the questions so far. But what we can, a couple of people have said as they start using the tool, they may have some questions. So we'll create a space for that and gather those in and then manage those from here.
Just on that, Amajit, is there a group forum or a group chat or anything for healthcare home leads to raise questions and everyone to see answers?
There's certainly a forum for healthcare home leads, and what we've been doing obviously is opening that up wider and using the likes of the Quality Improvement Network and HQSC in terms of their contacts. But obviously this forum, I've got everybody's email now. What we're trying to do in terms of the collaborative is reach every PHO in terms of, the support. So because somebody may have missed this opportunity this morning, so obviously with the recording we can share that as well. So yep, we can, I suppose in short, there is a leads forum. We've opened it up wider, and we'll just make it more explicit following this. Was there any final words from you, Chris, or no other questions coming through? As I say, we'll create that forum. Do you want to? Yeah. Otherwise, look, we can.
Yeah. Look, just thank you for listening in, and hopefully this will be useful for you as you work with your practices. And just remember, it's incredibly flexible. So whatever circumstance you find yourself in, there's often a way to work out how to make it work in the model. So if you can't get it to work, post on the forum and I'm sure someone can help, or I'll be able to help too. But no, thank you, and appreciate you taking the time. And I've given you an hour back on your day because we're an hour short of the 2.5 that we thought we might need. So I hope you appreciate that.
Yeah, thank you, Chris. There's certainly a few other additional, not so much questions, but comments of saying really useful, really easy to follow, and yeah. So thank you so much. It'll be helpful. And Mark Villa has just asked when will he be getting the tool. We can, if there was a couple of tweaks you needed to make following the feedback, we can get that. I can certainly get that out to people ASAP.
Yeah, it won't take long. A day or so.
Awesome. Yep. But yeah, thank you, everybody. Have a great day, and keep on doing what you're doing.